Hello guys, this is a chapter summary, chapter 32, first chapter on the approach to the patient with cardiac arrhythmias. This is my chapter summary. I just read it, I just underlined it, so it's basically the things I thought were important. So uh, remember, things that are important to me might not be important to you and vice versa, but this is the gist of the chapter, at least what I'm trying to show it to you guys. So first, the general approach. We have a wide spectrum of clinical presentations. We can go from asymptomatic incidental ECG findings to survival from sudden cardiac arrest. Palpitations, it's in bold because it's one of those symptoms that might be there, although it might not be present. So palpitations with a post extrasystolic beat can also exist in the setting of a completely normal cardiac rhythm. So it doesn't mean there's always pathology, but when you're suspecting pathology and you have the palpitations, it may be a sign that this is a cardiac in origin. So many patients are accurately aware of any cardiac irregularity, whereas others are oblivious even to long runs of a rapid ventricular tachycardia or AFib. Patients may use terms such as pounding, flipping sensation, fullness, or skipped beat in order to characterize a symptom that they have never felt in the past. So be ready for descriptions and characterizations of these symptoms in manners you might didn't even expect. Remember that this is based on the tools of each patient, the education level, etc. Anxiety over such symptoms is usually a complaint. So don't ignore the anxious patient just because you think they have anxiety. It might be the manifestation of these symptoms. If the premature complexes are frequent, or particularly if a sustained tachycardia is present, more likely patients are more likely to have additional symptoms. Then the longer they are exposed to this, or the more frequently, probably the more symptomatic. But remember, they might not be symptomatic. So low risk features are important to distinguish from high risk. Which ones are low risk features? They include isolated palpitations, not induced by exercise, the absence of structural heart disease, no family history of sudden cardiac death, and a normal 12-lead EKG. Now, it's important to note that if you have a patient with a supraventricular tachycardia, remember that even supraventricular tachycardia can give you symptoms of myocardial ischemia. It can even produce a type 2 myocardial infarction. Why? Because these patients probably have coronary artery disease, and with heart rates that are so fast, they might have a unbalance between supply and demand. So the onset, and you have to see the symptoms in the context of the patient. One thing would be supraventricular tachycardia in a young adult female with no predisposing cardiovascular risk factors, no cardiac history, no family history. And on the other side, you have the adult, old age male with an acute myocardial infarction recently with tachycardia. It could even be sinus tachycardia secondary to an infection. This patient is more prone to any complication. So the onset and offset of the palpitations could suggest the etiology. When you have sudden, abrupt onset, like a light switch turning on, this is consistent with a paroxysmal tachycardia, such as atrioventricular nodal reentrant tachycardia. whereas gradual speeding and slowing is more consistent with atrial or sinus tachycardia. Termination by Valsalva maneuver or carotid sinus massage suggests a tachycardia incorporating the nodal tissue in the reentrant pathway. Then we have patients should be taught to count their radial or carotid pulse. This is important. Teach them. Ventricular rates of 150, exactly 150, you might think of a 2-to-1 conduction atrial flutter, AV block. Why? Because if it's not 2-to-1, it would be 300 beats per minute. We know that this would be incompatible with life, would generate, the patient wouldn't be speaking to you, would be completely unstable. Then usually 2-to-1 block means 150 beats per minute, whereas most supraventricular tachycardias, such as those caused by AVNRT or AVRT, usually occur at rates exceeding 150. Bradyarrhythmias may also produce palpitations. Why? Because you have an extended ventricular filling, which would mean more volume ejected, generating this palpitation. Now, what about syncope, pre-syncope, and altered level of consciousness? So, any cause of cerebral hyperperfusion, in this context, we are talking about syncope, or any alteration in cerebral perfusion, which leads to a loss of consciousness, which is abrupt in onset and is usually reversible, we're talking, that would be basically the definition for a syncope. So we should always look for the cause of this syncope. It is important to distinguish syncope from other causes of transient loss of consciousness, like what? Neurologic, we have seizures, metabolic disorders, like hypoglycemia, hypoxemia, intoxication, cataplexy, and pseudosyncope. So I'd probably differ with cataplexy, because I think that in cataplexy, there's no loss of consciousness, and actually you're just locked into that state, and it wouldn't be, if it were a loss of consciousness instead of cataplexy, I guess we would be talking about I guess we would think of cataplexy as a sort of epilepsy, but I think that's not the case. This video might be uploaded. It's my own summary. If it works for you, great. But one of the ideas of uploading these videos is that if you can correct me in anything, I'll learn from you, so let me know. Syncope table 32.1. What is the criteria for immediate evaluation? So most of these patients will end up in the emergency department, and with which patients do you have to be closer to and look for possibilities which would be life-threatening, and not tell this patient, okay, we're done with you, you're okay, you can go home. Which patients need immediate evaluation? We have those patients in which you suspect any sort of structural heart disease. Why will you suspect this? If the patient has heart failure, or significant left ventricular dysfunction or hypertrophy, or prior myocardial infarction. So this would be based on the clinical exam, the history, and EKG or an echocardiogram if you have one there. Clinical features, exertional syncope. This is interesting because you could have exertional syncope or syncope while supine. So what is the syncope associated? Which syncopes require immediate evaluations? Usually those that are called malignant syncope. So you have benignant, benign, and malignant. What's the difference? Usually when you think of a cardiac origin for syncope, you're talking about malignant. Why is this malignant? Because they usually pose a life risk, while benign would be, for example, the majority of them which are neurally mediated. For example, it's emotional, stress, or the most common would be vasovagal or neurocardiogenic. This one would be benign because you have no cardiac abnormality, no structural abnormality, and risk for sudden death would be relative would be low. So when we see this table, remember that in immediate evaluation, you are thinking of this malignant syncope or cardiac based. So what are the clinical features for you to think about this type of syncope? Exertional. So if you're working out, a patient was running and had a syncope, pay attention to that patient. Or this is the strange one, which would be syncope while supine. You were supine and let's see, yes, supine, and you had the syncope. So it would be counterintuitive, but have it in mind. Then we have palpitations associated with syncope, family history of sudden death. Then we have the electrocardiographic features. Which electrocardiographic features? We have ventricular tachycardia, bifascicular block, QRS duration more than 120 milliseconds, or a complete bundle branch would be, by definition, QRS more than 120. Then we have sinus brady, less than 50 beats per minute, or sinoatrial block. Then we have pre-excited QRS, prolonged or short QT, Brugada pattern, T-wave inversion, and late potentials. Those would be electrocardiographic features which would make you evaluate this patient immediately. And significant comorbidities would be anemia and the electrolyte disturbance. So if you're in the ER, which is the place where you'll be frequently when you see these patients with syncope, and you have any of the aforementioned characteristics, then pay attention to these patients. These patients require the cardiologist to check them out. Then we have seizure activity is uncommon and occurs when we are talking of this cardiac source. Seizure activity is uncommon and occurs mostly after prolonged asystole or a rapid ventricular arrhythmia. Seizure does not begin with or anticipate the syncope. In epileptic seizures, convulsive movements start within seconds of the onset. Tongue biting or incontinence is also uncommon in cardiac syncope. Common arrhythmic causes of syncope include bradyarrhythmias caused by sinus node dysfunction or AV block, and tachyarrhythmias, most often ventricular. Of the reflex syncope, it should be differentiated from syncope by orthostasis, which may be seen in autonomic failure, diabetes, amyloidosis, for example, Alzheimer's. Vasodepressor and cardioinhibitory unfold more slowly and can be preceded by manifestations of autonomic hyperactivity. Then we have palpitations and presyncope on standing can be symptoms of postural orthostatic tachycardia syndrome, which we'll talk a little more next. Take into account the medications the patient uses, because, and mostly in elders, this may be producing the orthostatic hypotension or bradyarrhythmia. And then we have non-arrhythmic cardiac causes, which can be excluded by history, physical, EKG, echo, and other laboratories. Okay, laboratory lab tests. Now, sudden cardiac arrest and aborted sudden cardiac death. It is actually not that uncommon, usually produced by cardiac arrhythmias resultant in ventricular tachycardia or ventricular fibrillation. But you also have causes that are non-cardiac that might be associated with life-threatening arrhythmias, like what? Neurologic disease, diabetes, obesity, cirrhosis, anorexia, and bulimia. Coronary heart disease is the most common finding in sudden cardiac death and can be the first and last manifestation. Up to 80% of cases of sudden cardiac disease, sudden cardiac death, patients have some structural heart disease. Other causes of sudden cardiac death as autopsy negative. So in the autopsy, you don't find anything because the alteration was a channelopathy or something which couldn't be seen macroscopically, like what? Long QT syndrome, Brugada syndrome, catecholinergic polymorphic ventricular tachycardia, idiopathic ventricular fibrillation, and Wolff-Parkinson-White. So remember, Wolff-Parkinson-White isn't as benign as you could usually think. You have to pay attention to this. These patients might develop sudden cardiac death. A history of cardiac disease is critically important in directing the evaluation. Circumstances are often informative, so always pay attention to what was happening around the patient in those moments when the patient had the syncope. If the patient is in the ED with his friend, ask the friend, because the patient, well, in those moments, the patient might remember till he had the syncope or loss of consciousness. So these circumstantial events around happening in those moments would be important. Cardiac symptoms that predate SCD suggest pre-existing structural disease. Precipitant factors can provide clues. Then we have some characteristics that SCD and long QT syndrome type 3 or Brugada syndrome is more likely to occur at rest or with sleep. So patient tells you that this happens during sleep or it happened at rest. Okay, it could be one of these bad guys, type 3 long QT or Brugada. If this was produced by fever as a precipitant, think of Brugada. And also medications and recreational drugs must be questioned for. So you have two different websites to go into to check if any of these might produce QT prolongation or any other alteration leading to this. This EKG that you're seeing here is the EKG with the typical pattern of type 1 or type A Brugada phenotype. Look at the difference. Upper right, you can see that there is a change in where the precordial leads V1 and V2 are placed. Instead of fourth intercostal, parasternal, these are placed in second, because in second you can see the right side as right precordial leads. You can see the manifestations better. Then you can compare V1 prime, V2 prime with the curved ST and compare that with the lower right V1 and V2 which are placed at the fourth intercostal. Which are the physical findings? So I think we have to pause this video for a second because I'm short of battery. Give me 1 second. Physical exam. It says the absence of significant cardiopulmonary disease often, but not always, suggests benignity. Palpitation, syncope, or near syncope. Well, I'm going to try to bring my charger. Give me 1 second. We'll keep on doing this. Palpitation, syncope, or near syncope in the setting of significant heart or lung disease have a more ominous prognosis. Estoy haciendo una grabación y se me está quedando sin batería el hijo.
¿Y tú qué cosa?
Sí, tengo que ver cómo lo edito. Gracias, ma. Okay. Sorry for my correct Spanish. I said some foul language because I don't know how to edit these videos. I'll try to cut out the part that was this interruption. Give me 1 second. Okay, we're ready. We have electricity. So, 1 second. Okay, so physical findings. Absence of significant cardiopulmonary disease often but not always suggests benignity. Palpitation, syncope, or near syncope in the setting of significant heart or lung disease have a more ominous prognosis. If a tachycardia is present, priority is obtained 12 lead EKG. The Canon A waves in the physical exam would be consistent with a 1-to-1 retrograde ventricular or atrial activation if the Canon A waves are regular. So which types of a 1-to-1 retrograde ventricular atrial activation? AVRT, AVNRT, and some junctional tachycardias and ventricular tachycardias. In contrast, AV dissociation such as could produce intermittent Canon A waves, and variable peak systolic blood pressure is more consistent with arrhythmias, including VT and non-paroxysmal AV junctional tachycardia, without retrograde capture of the atria. Then we have the carotid sinus massage. This is important. It could interrupt certain arrhythmias, which are sensitive to autonomic tone, and identify the patients with a hypersensitive carotid sinus reflex. Carotid sinus massage generally does not affect reentrant ventricular or junctional tachycardia. So in this figure, what we are seeing is the right carotid sinus massage. Remember, before doing this procedure, you have to first auscultate, then press gently, and third, do the massage. And you should always do this in a monitoring the patient. I know that generally we can do this without monitoring closely the patient, but look at this case. It produced a sinus arrest and a 7.2 second pause in a patient with episodic dizziness. So watch out. Clinical and laboratory testing. Cardiac imaging. It has an important role in identifying structural abnormalities that can render the heart more susceptible to arrhythmias. For instance, ventricular systolic dysfunction and chamber dilation in hypertrophic cardiac myopathy and in the setting of infiltrative disease. In this figure, we can see sarcoidosis. On the left, we can see 18-fluorodesoxyglycose uptake. And in figure B, we can see two cardiac magnetic resonance images that show evidence of delayed gadolinium enhancement in the midwall. What about resting electrocardiogram? There is no test more important than this one. Remember that this one, you usually have access to it in the ED department. First thing you'll do is tell the patient, come here, we're gonna do an electrocardiogram, 12 lead EKG. This will give you important information. Even in unstable patients, you do this because it will give you a swift information, and you need to know this in order to detect determine what your next step will be. So there are some uncommon but diagnostically important signatures, as are delta waves in Wolff-Parkinson Wolf, Parkinson, White. Okay. Prolongation of shortening. I just had these things you call a lapsus brutus. Wolf, Parkinson, White. Yeah, of course. Things you've read hundreds of times and you suddenly forget for a second, I think that would go into the lapsus brutus section. So, prolongation of the or shortening of the QT interval, right precordial ST segment abnormalities characteristic of Brugada, and the epsilon wave seen in arrhythmiogenic right ventricular dysplasia. But remember that it's now named arrhythmogenic ventricular dysplasia because it can affect the left ventricle as well. So signal average electrocardiography might work out because it can amplify small potentials, which are referred to as late potentials, and these are usually associated with ventricular arrhythmias after MI. What about Holter and event recording? It could be continuous EKG recording, which is useful. Well, it's continuous. This means continuous EKG recording, which is useful in detecting dynamic changes in the ECG segments and intervals. Changes in the ST and T waves may signal ischemia and the dynamics of heart rate variability and QT variability, which may indicate arrhythmic risk. The type and duration of ECG monitoring depend on the frequency of the symptoms. Okay. Wireless ECG recording systems. There's different options for them. And if you have a short-term continuous monitoring, we're talking about 24 to 48 hours. Generally, this is called the Holter monitor, named after the person who invented this technology, and it's sufficient to adjudicate patients' daily symptoms. If the patient doesn't have daily symptoms, so you probably need longer term monitoring for arrhythmias that occur less frequently. And if you have patients that do not have symptoms frequent at all, you will probably need an internal loop recorder that goes on to record even longer, even 24 to 36 months. Here we are seeing examples of the different modalities. This is a real-time monitoring of the EKG with a smart app. With the iPhone, here we can see this other monitoring system. It says adhesive electro patch that allows for long-term continuous recording of the EKG. And the summary page shows patient trigger events. Usually the patient has a trigger, which when the patient feels he or she has the symptom, will touch, and that's where the recorder will start recording before and after the press of a button. Then we have stress electrocardiography, which is particularly useful in the evaluation of patients who experience symptoms with exertion. It is important in determining ischemia and other arrhythmic substrates. T-wave alternance is important, and altered heart rate recovery may indicate autonomic dysfunction. Not all arrhythmias induced by exercise have an ominous prognosis. 1/3 of individuals without heart disease will have them. Which ones? The occasional uniform premature ventricular complexes. If you have more complex premature ventricular complexes, then you will have to study them. Switch ones? Multiform premature ventricular complexes, pairs of PVCs, and ventricular tachycardia. Okay? During exercise testing, you should prompt a search for underlying structural heart disease. Okay, if you have multiform PVCs, pairs of PVCs, and VTAC, you should look for structural heart disease. Ventricular ectopy may be found in half of patients with CAD, coronary artery disease, and a lower and at lower heart rates, less than 130 beats per minute, and often in the early recovery period, you should go study these patients because it is unusual to see this in, let's see, premature ventricular ectopy, and it's strange to see ventricular ectopy in healthy individuals at heart rates less than 130. Frequent PVCs, which would be more than 10 per minute, polymorphic PVCs and VTAC are more likely in patients with abnormalities you gotta look for. Also has prognostic or diagnostic value in patients with primary electrical abnormalities. So exercise testing also works out for patients that have long QT syndrome, because these patients can be normal in up to 1/4 of patients when they are resting. But if you stress them out, it could be useful to expose the ECG abnormalities. In this patient, you can see before treatment. Here is where they detected her alteration, and this was a catecholinergic polymorphic VTAC. They administered her with the treatment, which would be nadolol and flecainide, and look how nice the ECG after this was with exertion. Head-up tilt table test, or the tilt table test, TTT, is usually the mechanism by which arrhythmias or the syncope is elicited isn't well understood, but we know that this tilt table testing produces redistribution of blood volume and increased ventricular contractility consistently throughout. There is an initial increase in heart rate followed by a drop in blood pressure and then a reduction in heart rate characteristic of neurally mediated hypertension. So here we could find the postural orthostatic tachycardia syndrome, also known as POTS, which is by definition an increase of more than 30 beats per minute in heart rate, which would be more than 120 beats per minute within 10 minutes of assuming an upright position. So this is oftentimes confused with anxiety, inappropriate sinus tachycardia, chronic fatigue syndrome, and fibromyalgia. Data tell us that endurance and strength training programs may be useful in its management. So don't be scared of the usual exercise and strength training. We know that exercise is usually beneficial in most circumstances. TTT is used most often in patients with recurrent syncope, particularly in the absence of structural heart disease. And it would be contraindicated to do this test on a patient with CAD with proximal coronary stenosis, non-severe cerebrovascular disease, severe mitral stenosis, and obstruction to the left ventricular outflow tract. In this study, we can see a tilt table test, and in A, we can see before the syncope. In B, we can see the sinus bradycardia and AV block that ensued and produced hypotension and syncope after 15 minutes of initiating the test. Then we have invasive electrophysiologic studies. The components of EPS are baseline measurements of conduction under resting and stressed conditions and maneuvers, both pacing and pharmacologic, to induce arrhythmias. Failure to induce an arrhythmia does not exclude the possibility that the patient has an arrhythmia. Ideally, we would think that EPS would induce a clinical and prognostically important arrhythmia in only patients who are at risk for spontaneous arrhythmia. But unfortunately, this is not the case. Now, what about the approach to specific symptoms or sudden cardiac arrest survivors. The approach or primary secondary prevention of SCD is defined by the presence of underlying structural and the reversibility of the initiating events. Directed therapy to improve the function, as in DCM and HCM, or reduce inflammation, as in myocarditis, sarcoidosis, but generally mandate an ICD placement. Patients with heritable arrhythmia syndromes should have an ICD placed. Pharmacotherapy such as beta blockers in the catecholinergic ventricular tachycardia, polymorphic ventricular tachycardia, or long QT syndromes type 1 and 2, and in some patients, lifestyle modifications. Syncope. Majority of patients with syncope have a non-cardiac cause. Cardiac cause is suspected. If it's suspected, do an echocardiogram and ambulatory ECG indicated. EPS study occasionally. Suspected of neurocardiogenic causes often includes a tilt table test. What about bradyarrhythmias? Establish that the bradycardia produces the symptoms before assuming that therapy is required. Symptomatic bradyarrhythmia may require no further diagnostic testing. Type 2 second-degree AV block, the demonstration of his Purkinje block is sufficient to justify a pacemaker. Asymptomatic sinus brady of 35 to 40, sinus arrhythmia with pauses of 2 to 3 seconds, Wenckebach second-degree AV block, particularly during sleep, wandering atrial pacemaker, and junctional escape can be completely normal, especially in young and in well condition. EPS is indicated when a causal relationship between the appearance of the bradycardia and the patient's symptoms cannot be established, or to exclude a tachyarrhythmia as the cause. Exercise, atropine, or isoproterenol can shorten the PR during type 1 or Wenckebach AV nodal block, whereas increase in the block P waves in type 2 second-degree AV block. Now, what about tachyarrhythmias? 12 lead EKG is invaluable. A QRS morphology that is identical to that presented during sinus rhythm, even if abnormal, suggests that the tachycardia is supraventricular. If you have wide complex tachycardias, particularly if different from the QRS in the sinus rhythm, and especially in history of MI, they are almost always VTAC. Supraventricular can be classified based on the temporal relationship of the P wave and R wave. When a P wave occurs closer to the preceding R wave, called a short RP, whereas in the second half, it is called a long RP. So which ones produce a short RP interval? They are AVNRT, AVRT, junctional tachycardia, and atrial tachycardia with a markedly prolonged PR. If no P waves are present and the RR interval is regular, then you're thinking of AVNRT. If a retrograde P wave is present, AVRT is most likely. Long RP include which ones are included in long RP? Tachycardia, short complex tachycardias, sinus tachycardia, atypical AVNRT, permanent junctional reciprocating tachycardia, and atrial tachycardia. Conduction over an accessory pathway during sinus rhythm or during tachycardia suggests that it's Wald-Parkinson-White. Now, evaluation and management of athletes with arrhythmias, often exhibiting remodeling. Cardiomegaly is an adaptation. So with endurance training, you'll have four-chamber enlargement, which is secondary to volume overload. With strength training, you'll have a pressure overload, which will produce concentric increase. And you have basketball, for example, in which you have both types of loads, so both type of growth. ECG changes, you have left ventricular hypertrophy approximately in 40% of the athletes, T-wave inversions in precordial leads V1 to V4 up to 14% in African American athletes, QT prolongation, frequent PVCs and sinus brady, as well as various degrees of AV block during due to increased vagal tone. Arrhythmias with increased frequency in competitive athletes. Most common medical cause of death is sudden cardiac death in athletes, 1 in 53,703 athlete years. So it's, since there's more sudden cardiac death, you'll also probably see more use of the AEDs in high schools with 3.65-fold increased risk compared to non-athletes. Intense exercise can trigger arrhythmogenic sudden cardiac death in an athlete without cardiac disease. Risk assessment is challenging. There's controversy using routine 12-lead EKG depending on the country you're at, but the ACC is an advocate to the use of a 14-point pre-participation history and physical, acknowledging that athletes with underlying CV disease may manifest warning signs and symptoms elicited by a cardiac full history and physical examination. It includes a history, so chest discomfort, unexplained syncope or near syncope, excessive and unexplained fatigue, dyspnea, palpitations with exercise, prior recognition of a heart murmur, elevated blood pressure, any alteration which goes out of the norm, pay attention to it. Also, family history with sudden and unexpected death in family members less than how many years old? 50 years old for these events in family members, usually first degree. And we have also family history of heritable heart disease, cardiomyopathy, or primary electrical disease. These should be referred to the cardiologist. And this table is pretty nice. You'll see in a second how we organized it. So pay attention here. This is a nice way to remember which are the indications for referral or workup of arrhythmias in athletes. I have no idea why these tables aren't made in an easier to learn fashion. Look at this. In green versus red, what makes you worry the most? Probably the color red versus the color green. So color red is that if you have any of those in the color red, you don't need to ask the patient anything else. If you have this diagnosis in color red, just go forward and refer all these patients, all these athletes for further workup with a cardiologist. So which ones are in red? You have second degree type 2 AV block, third degree AV block, complete right bundle branch block, or complete left bundle, atrial fibrillation or flutter, AVRT or AVNRT, or Wolff-Parkinson-White. So which are the patients you have to now individualize based on if they, on the degree of alteration they have. So these are the patients in the green boxes. As you can see, look at all those lines that are going out of each of these, which end up joining in this second column, which would be for all these diagnoses that have lines and that gather up with the three different lines seen in green. Those are basically the alterations we want to see. So if you find any of these diagnoses in green, plus the patient has cardiac symptoms or family or personal history suggestive of heart disease, or physical exam indicative of heart disease, refer the patient. Now let's go one by one on these specifics if there's anything else to add. If the patient has severe sinus bradycardia, what are we talking about? How many beats per minute in an athlete? We're talking about 30, less than 30 beats per minute in an athlete, not 40, 30. Or bradycardia sinus pause more than 3 seconds while awake, or signs and symptoms of sinus node dysfunction or disease. Okay, now for first degree AV block, specifically if it does not resolve with hyperventilation or exercise. Also, second degree type 1 AV block, if it does not resolve with hyperventilation or exercise, refer the patient. Then we have incomplete right bundle branch block. The go-to, the three symptoms or findings we mentioned before. Left ventricular hypertrophy by voltage criteria. If you have ECG markers of pathologic left ventricular hypertrophy or symptoms. Then repolarization abnormalities if you have early repolarization in inferior and or lateral leads. Why? Because it's frequent to find these repolarization abnormalities in the precordial or initial leads. Then we have premature ventricular complexes, specifics, 2 or more PVCs on screening EKG or increased PVC frequency during exercise. Okay, that's it with this table. It's very nice. I think I grouped it pretty nicely. So be sure how to use it. And there you have it. Maybe my explanation wasn't the best, but we're working on that. Okay, we're working on that English mainly. In Spanish, it's fluent AF. So physical activity in patients with ICVs is often a question, but recent registry data says it's safely to participate in some athletic activities with some restrictions. And that's it for this chapter. We're over.